No, were you surprised by the results from AIR223?
No, I wasn't surprised at all.
Yeah.
We did a lot of basic research on this topic in the late 80s and early 90s and published on this, and one has to understand the relationship between osteoblast bone formation and osteoclast resorption. There's a thing called a remodeling cycle. It's a little bit like filling the roads. A hole appears, the workmen come along and fill it in. And this is a constant replacement process. So the whole skeleton's replaced every 2 or 3 years. And you don't kind of realize that when you're thinking about bone, because there's a concept that bone's pretty constant, and actually it's not. And what we looked at this, and we looked at it after we'd seen data in relation to induced menopause in breast cancer. And what was known then was that women suffered an acute loss of bone volume within 6 to 12 months of the hormones being switched off. And so we ran a controlled study where we looked at loss of bone volume in men who were having orchidectomy, because that was the treatment at that time, and how we could prevent that, and we looked at it in detail, bone biopsies, bone breakdown markers, and so on. And what we found was that there's an acute drop in bone volume within 3 months of ADT, and that is largely produced by an osteoclast surge. And you can block that osteoclast surge with a bisphosphonate, and at that time it was permidronate that we used. And so what we have in this setting here is a group of men who've had a serial insult to the skeleton. So they've had ADT, they've then gone on and they've had abiraterone, super ADT, they've had prednisone, and then, hey presto, they get a hit to the bone marrow from radium-223. So what the Abi and pred will do is inhibit osteoblasts. What the radium will do is inhibit osteoblast precursors in the bone marrow. Osteoblasts are basically fibroblasts. They come out of the fibroblast lineage. All the osteoblast precursors are in the marrow. So you have multiple hits to the skeleton outside of the skeleton affected by the tumour specifically. Now, put that to one side and then ask the question, what kind of people are these that are actually having treatment? They're older men. We know that they're presenting with a degree of osteopenia in a significant number. 25+% are osteopenic. And what we also know is when you treat an osteopenic male with ADT, the osteopenia will get worse and become porotic in a proportion. Add to that this extra insult, which is you stop all of the repair processes and you have an osteoclast surge, which you haven't inhibited because you haven't given bisphosphonate. And, well, it's not a surprise to me.
So you think it's a lot to do with the timing of the abiraterone with the radium? Because I mean, quite a lot of people would have layered radium on top of abiraterone, where somebody was already established on abiraterone therapy and then radium is added on progression. You think that's different then than this situation where they're both been started around the same time?
Well, I think it just adds an insult to an insult. And I think you'll mitigate that to a certain extent, but you won't mitigate it completely. And as Nick's pointed out, the abiraterone fracture rate was greater. And again, you'd expect that. And that's an osteoblast bone formation effect, which you're blocking. You won't be able to affect that with a bisphosphonate. You'll affect the resorptive surge which you get with an androgen hit.
So something else, Noel, in this context is we know the bone scan is predictive of response. Basically, you're looking on a bone scan, you're looking at the osteoblastic response, and it's the osteoblastic response that is the osteoblast. You know, the increased uptake of technetium on the bone scan is the increased uptake of radium when you give it therapeutically. Now we know if you give early on, if you look at bone scans in patients responding to any cancer treatment, doesn't matter which one, you get an increase in osteoblastic activity as the bone mets heal up. So therefore you'd be getting a bigger dose of radium if you give it at the same time as you start the abiraterone, which you're not seeing if you layer it, I think. And the other thing, just to segueing slightly into the M0 abiraterone data, the patients in whom we saw the biggest benefit in terms of failure-free survival were the men who had abiraterone and radiotherapy. So the hazard ratio for the whole trial on failure was about 0.3. The hazard ratio for Abi plus radiotherapy was less than 0.2. And the test for heterogeneity was significant. It was a clinically significant increase in effect. So it looks like there's synergy between radiotherapy and abiraterone. So we've upped the osteoblast reaction. We've given a radiosensitizing agent, then we've given a radiotherapy treatment. And lo and behold, we're seeing big effects. I mean, it's obviously easy to be wise after the event.
Yeah, exactly.
So I have to say I wasn't so sure that we would see the harm that we saw,
Yeah.
but I think you can explain it now. And I think given the data from Alsimca, and again with the benefit of hindsight, it's a shame that bone protection wasn't mandated, because it looks like the results in Alsimca are generally better if you give zoledronic acid at the same time, and by extension denosumab.
And there's some suggestion from the early access program as well that patients who were getting concomitant denosumab or Zamita were also benefiting in terms of survival.
Yeah, so I think with hindsight that would have. The other thing I think was a shame was that there were other things that maybe the DMC could have done, like stopping, insisting all patients had bone protection and carrying on the randomization in that subgroup. Yeah. Because I'm not sure what the evidence of harm in the subgroup getting bone protection was sufficient. And if you look at some of the cancer-related outcomes, like spinal cord compression, it's reduced in the combination therapy. So I think it's a shame. I think it's potentially produced negative data that could have been ameliorated by running the study longer and just stopping the dangerous bit of it, rather than stopping all of it.
Yeah,
and it's kind of muddied the waters, and we've ended up not learning what we might have learned from the combination therapy, because it's not clear to me that the combination may not in the long run have turned out to be better if you ameliorated the early issues.
Yeah, I mean, it's a little, the baby being thrown out with the bathwater like this is a little bit like the 1976 BIOS study with estrogens. Because when you look in detail at that study, it was 1,700 patients. It's quite fascinating, because the prostate cancer specific survival is very much better with estrogens than it is, but you lose it on the cardiovascular events, of course. And what we're just re-examining with the estrogen patch trial, which has been hitched to Stampede, is whether, I mean, what we know from the data already is that metabolically, the estrogens used using patches as a primary androgen deprivation actually are metabolically much more, or much less harmful. Lower cholesterol, lower blood pressure, bone preservation, and so on. What we don't know is whether there's actually a cancer benefit from that. And so we've had an interval from 1976 to whenever a report on patch will be probably 21, 22. And that's largely from the same phenomenon, which is a positive anti-cancer effect has been ignored because of a toxicity issue, which is probably avoidable.
Which could have been catered for or covered, yeah.
So I mean, you're involved with both the patch trial and of course the Stampede, of course, you're involved with. But I think it's going to be very interesting to see how that pans out, because there's obviously no pharmaceutical support for estrogen patches,